Thank you for joining us for this special series of This is Getting Old, sponsored by the 2020 George Washington University's University Seminar Series. Towards Age Friendly is brought to you by Melissa B., PhD, in collaboration with GW Center for Aging, Health, and Humanities. Welcome to This is Getting Old. I'm your host, Melissa Batchelor, and today we're going to be talking about the 4M's framework and specifically about medications. And this is a continuation of our special series on the Age-Friendly Health Systems Initiative. If medications are needed within the 4M's framework, we just want to be sure that that medication does not interfere with the other 4M's, which are what matters, mentation, and mobility across care settings. Today, I'm joined by Drs. Tahira Lodhi and Ayo Bankole. So before we begin, I would like each of you to introduce yourselves, and then we will dive into how to make sure medications are age-friendly.
Hi, I'm Tahira Lodhi. I'm one of the geriatrics and palliative care physicians with George Washington University. I have practiced here for the last 9 years, and besides my patients, other learners that I've interacted with are medical students, residents, and geriatric fellows. So a whole range. Because I am involved in different levels of care, from not only the classroom, but also clinic, bedside, and long-term care facilities, I have my patients over the entire range. So I practice 4M's in my entire range of practice every day.
Great. And Ayo?
Hello, my name is Ayo Bankole, and I'm a clinical assistant professor at George Washington University School of Nursing. I'm also a senior clinical instructor at MedStar Washington Hospital Center. Both of my practice and research backgrounds has been in aging and chronic disease, and I also teach pharmacology to undergraduate students in the School of Nursing. So my overall research goal is to improve quality of life for the older adult population, and the 4M's framework merges very nicely with my overall research and also my practice goals.
All right, thank you. So let's get started. Let's just do an overview of why medication is such an important part of the 4M's framework, and what are some of the things that providers need to be aware of to avoid problems.
So the first thing that I would talk about is defining what polypharmacy is, or what is too many medications in simple terms. It has different definitions put forth by different entities, but basically, I would say when you see a patient with a medication that does not have a corresponding diagnosis documented, that's polypharmacy by one definition. The other is if your patient has more than 4 or 5 medications, that's polypharmacy. So whichever situation you're in, whether you're by the bedside, in the hospital, in outpatient or long-term care settings, be very aware of these definitions of polypharmacy and be ready to address them.
Right, and actually in the United States, the average number of medications an adult over the age of 65, the number of medications they take is like 5, and most of them are on, more than that. So Ayo, any other things that a provider would need to know?
For the provider aspect, as clinicians, it's important to provide or perform a medication reconciliation that each patient can encounter. So medication reconciliation involves reviewing the list of medications that this patient is taking and comparing that medications on file comparing those medicines to the medications on file to ensure there's no discrepancies such as medications duplication or missing medication, or also inappropriate medications as well. And medication reconciliation should be performed at every patient encounter.
Right, and so it's not only comparing the list that's kind of in their medication administration record, whether you're a nurse or a physician, or pharmacist, comparing that to the list that the patient has brought to you, but then also looking to make sure that whatever medication it is, that there's an active diagnosis. And so you're reconciling kind of those 3 levels. So
and if I may add, I'm sorry.
Okay.
If I may add, the medication list is not only the medications that are prescribed by a physician or a nurse practitioner. It also includes other medications that might be over the counter, supplements that your patient might be taking, and at-risk medications that might be included in your patient's list, and they just haven't put it on the table. If your patient is going to multiple providers, make sure that you include the question to your patient about any change in medication since the last time you saw them.
Right. I think this is one of the things, actually, I had talked about, when you get that medication list from the hospital or from your provider, it's kind of all in a list. And so what were some of the things that you and I had talked about doing, like when people transition home?
Yeah, so it's very, very important because a lot of times a lot of patients get overwhelmed because you're on a lot of medications. So it's very important to keep a medication list, and it has to be updated at every time. So this medication list includes any medications you're taking, and this includes vitamins and supplements or herbal supplements as well. And keeping an updated medication list will help you keep track of what you're taking and also help you stay organized as well. Also, keeping track of your medication list will help you in emergency situations, because sometimes during emergencies, patients may not be able to remember what they're taking or what medications they're on. And so having a medication list certainly helps. A medication list should include information regarding the name of the medications you're taking, the dose, what the medication is used for. And this also includes over-the-counter medicines, like I mentioned earlier, vitamins, or any herbal supplements, or any complementary alternative therapy medication. And also, a medication list should include your prescribing doctor. And also, whenever there's a change to a medication, you can always edit the medication list accordingly. And it's also very important to include the dates, and at the time, the dates of it's very important to keep the dates that you edited those medications or you assembled those medicines, so we know that this medication is up to date. And also have phone numbers of your pharmacist or your doctors on the list as well.
Right. And I think that you definitely need to keep that list for like an easy at a glance thing. But when you're actually helping someone manage their medications or you're managing them yourselves, to think about either using a pill box, but I think of, documenting what you've done. And so, but by the day, I can remember my mom, she came home from the hospital after some surgery, and I looked at the medication list and was like, oh my God, like some of these things are twice a day, sometimes 3 times a day. And so I just like took out a sheet of paper and went like morning, noon, afternoon, evening, and then filled that in real time, because just looking at the list is hard to know. And then if 2 people are trying to help someone, at least you've documented when that person is taking that medication. And I think pill boxes just help make things more efficient too.
Yeah, I agree. A lot of people use the pill boxes, and some people have alarms on their phone to set when it's time to take a medication, especially medication that are multi-regimen that you have to take throughout the day. So, yeah.
Right. And I wanted to circle back to one thing that you were talking about, Tahira, but this concept of bringing everything in, like there's a term for that.
Right. The brown bag review. So what it is basically teaching your patient to gather all the medications, put them in the bag, and bring them on every visit. And we as providers have a responsibility there to not only educate our patient and their caregivers, but also maybe help them remember that. Give them maybe a bag with a name on it, so that with brown bag or whatever, so that whenever they're coming to see you, they remember this is the bag they need to carry with them to come and see you. And once they are in the clinic, either your medical assistant or you yourself take out those medications, put them on a table where the patient can see it. What this does is brings you and your patient on the same page about what medications they are taking exactly, what supplements they are taking exactly. Ask your patient. This is a great opportunity to know whether your patient is aware of why they're taking this medicine, what dose they're taking. A lot of times when I ask my patients, they tell me, oh, that little blue pill you gave me is not working for me. So if I have the little blue pill in front of me, I know exactly what they are talking about. Otherwise, there could be a million blue pills prescribed by different physicians. So brown bag review is a very valuable tool we can use as providers to make sure we can avoid polypharmacy in our patients.
Yeah, I actually had a patient one time that didn't have a high reading level, and took a sheet of paper and did like the morning, evening, the 3 times a day, and then taped the pill and then wrote the name out, and then, so that they could so it was very clear about what do you take in the morning. Here's the pill, taped it to the paper. And then also, like, do you have to monitor your blood pressure for this? Do you have to monitor your pulse? Do you have to, to monitor, your weight, like whatever it is, but put it into like a real-time document versus just the list that you get. That really takes quite a bit of thought to make sure you don't end up with a medication error.
Our patients are very smart, actually, patients and caregivers. I have patients in the long-term care settings whose caregivers actually put a pill with the name and indication next to it and put it on their refrigerators. I thought that was so smart for patients with cognitive impairment, especially, to have those pills on their refrigerator, have the names and the indication and the dosages right next to them. And, that way we at least can do our best effort to make sure they're taking the right pill.
Right. And there's a lot of technology out now also. I mean, there are pill dispensing devices that you can put all your medications in, and it will alert you, just like I was talking about with, even putting it on your phone. So I think, how do we use technology to help prompt and remind people, but then also teaching them, like, if you gained 5 pounds overnight, if you need to weigh yourself daily, they also need to know when to contact the provider. So if a student or someone else is listening today, what are some of the other assessment tools that we need to keep in mind or to use when we're talking about medications with patients?
So especially when prescribing medications to older adults, certain criteria are available and they are validated tools. For example, Beer's list of medications is a medication list that is put out by American Geriatric Society, and this is a list of potentially inappropriate medications for the older adults, and they carry different side effects and potential complications and medication interactions, which account for a large part of adverse drug reactions in older adult population. The only thing, Beer's criteria list of medications is very easily available. The most updated one from American Geriatric Society from 2019. That's the most updated list. The only thing I would tell students to be careful about is Beer's criteria list of medication does not mean they are contraindicated. It means they are to be used very carefully, to be prescribed very carefully. So whenever you're prescribing a new medication, this is a good tool to go to see if this is an appropriate medication for an older adult.
Right. I think isn't it broken up by like use with caution versus like avoid?
Right. It is divided up into different classes of medications, potential interactions with other medications, what are the side effects to look for, and whether they are completely contraindicated in certain disease conditions, or when somebody is on another list of medications for potential interactions. It's divided into different parts, but that's what it is.
Right. And some of the bigger categories are benzodiazepines, opioids, things that are highly anticholinergic, any sedative or sleep medications, muscle relaxers, and then tricyclic antidepressants and antipsychotics. And I'll tell you, I think one thing that people don't really know, like commonly, is that, Tylenol PM, a lot of people will use that to go to sleep, but it has Benadryl in it, which is on the Spears criteria. And, at age 65, you really need to watch taking Tylenol PM because it increases your risks for falls. And that's really what each of these criteria are meant to do, is to try to prevent some of the bad adverse events. So Ayo, you had talked about a stop-start method, so maybe explain what that is.
So stop-start criteria is very similar to Beer's criteria that Tahira was talking about. And it's more commonly used in Europe, and it actually was developed by the European Consensus Group, but it could also be used here in the United States. Very, very similar. So the stop part, the stop and start are actually acronyms. The stop part represents, the acronym represents the screening tool of older people's prescription. And that first stop are the criteria that's similar to the Beer's criteria that medications could be stopped, suggested medications for discontinuation. On the other hand, we have the start part, which is the acronym screening tool to alert to the right treatments. And those are the right treatment. Those are the recommended treatments for older adults. So that includes the pneumonia vaccine and those recommended treatment for the older adult population. So Beer's criteria and stop start, they do have overlaps and they're very similar. However, there's not been any big differences in efficacy in regards to improving patient-related outcomes or decreasing polypharmacy risk. So they can be used interchangeably.
Okay.
Yeah.
And so what are some of the best practices that people should know about after we've done a medication reconciliation and reviewed the Beer's criteria and we're doing our brown bag? What are some other kind of basic principles to keep in mind?
So the basic principles to keep in mind are, whenever you see your patient, whichever level of care they are at, the first and foremost step to take is make sure you reconcile their medication list, as I referred to earlier. Look at the medications they are taking, make sure there is no polypharmacy, be ready to adjust the dose, ask your patient on every visit how they are doing in terms of the medication. For example, antihypertensives, look at their blood pressures, look at their self-monitoring of blood pressure, and if it's consistently on the low side, or there are signs of orthostatic hypotension that you're looking for, which can be basically a side effect associated with any antihypertensive medication, be ready to decrease the dose. And at the same time, have a plan how you're going to follow in future. If the dosage needs to go up, make sure you do it carefully, start low and go slow, and be ready to assess it on regular intervals so it's not missed. In all the settings, basically, your pharmacist is your friend, and be ready to call them. Geriatrics is interdisciplinary at all levels. In long-term care settings, your pharmacists watch your patient's prescriptions very carefully, and they make their recommendations on a regular basis because it's part of the regular monitoring and quality control at the long-term care settings. So make sure you reach out to your pharmacist for frequently, make sure you're on the both of you are on the same page as far as prescriptions are going. Your pharmacist can also help you if your patients are missing doses of medications, or if their medications have not been refilled for a certain period of time. You better go back to your patient and make sure they are taking their medications as prescribed. Reevaluate the medications. It should be every provider who does that at their level. Make sure the medications are being used as prescribed. But I think this responsibility falls more on the physician who's prescribing the medications. Make sure whenever you are asked to refill a medication, go back to your patient's chart and make sure this is a medication that should be renewed. There is an indication for renewal. So those are some of the things that we should always look for.
Right, and to even do the brown bag with your pharmacist too, because there are drug interactions, but there's drug food interactions, there's drug supplement interactions, and so just making sure that you're very clear about everything that you're taking. I can remember a family member actually switched their loved one to our service because they're like, well, she's getting ready to die. And just the first medication reconciliation, she was on an appetite suppressant and appetite stimulant and like something to make her sleep and something, I mean, there were like 4 medications that were all interacting with each other. And I just cleaned that up. And the next day she was fine. And they thought that I was like this miracle worker. And it's like, well, we just need to, medications can be good, but they can be bad if no one's looking. And, so I think that people need to be aware of that. Your specialist may or may not be looking at the big picture and is giving you a medication. They should be looking at all of your medications, but that's why it's important for, anybody going to see a provider that they have that complete list, take the bag with everything that you're taking. So do either of you have, go ahead. I was going to say final thoughts. So perfect.
Okay. I also wanted to add, especially patients experiencing polypharmacy, to monitor for any side effects or signs and symptoms of polypharmacy, which is usually as a result of medication adverse effects or drug interactions. And common symptoms and signs and symptoms to watch out for are loss of appetite, diarrhea, fatigue, and weakness, change in mental status, confusion, hallucinations, or change in mood and behavior. And it's important that we monitor this and make sure you notify your provider and actually have a conversation about with your provider about any kind of any signs and symptoms you may be experiencing with your drugs.
Okay, perfect. And you, Tahira?
I would say, technology can help us, but we have to know what technology is doing. I would leave you with this incident that happened with my patient with Parkinson's, who was obviously had to take his Cinemet, levodopa, carbidopa several times a day. So he had Alexa set up. Alexa used to remind him to take the medications. He was doing well. He came to see me one week and couldn't get out of the chair. I asked him what happened, and he said, I don't know what happened. I'm taking the medicines you gave me. Well, as I probed further, it so happened that Alexa was too bothersome and he pulled Alexa's plug. Alexa was not reminding me anymore. So we just put Alexa back and everything was back to normal.
Right. Yeah. There's so much technology that's out there. But thank you both for being with me today to talk about the 4M's framework and medication considerations that we all need to be aware of as we move forward towards widespread age-friendly health systems. So please be sure to check out the interview around the age-friendly health systems with Drs. Alice Bonner and Terry Fulmer, and the other podcasts related to the other 4M's, What Matters, Mentation, and Mobility. Thank you for joining us for this special series of This Is Getting Old, sponsored by the 2020 George Washington University's University Seminar Series. Towards Age Friendly is brought to you by Melissa B., PhD, in collaboration with GW Center for Aging, Health, and Humanities.